Thank you. My disclosures. Adaptive immunity in SARS-CoV-2 infection and disease comprises neutralizing antibodies that play a key role against infection and the interplay of humoral and cellular immune responses that play a key role in modulating the outcomes of the infection. For COVID vaccines that are based on the U1 or wild type spike of the virus, we know that there is partial escape from induced immunity related to the emergence of virus variants. The escape is particularly important for neutralization activity, but there is a lesser impact on T-cell immunity, reflecting the fact that there are epitopes across many different sites of the spike, including more conserved sites. So the overall ability of T cells to recognize virus variants is less impacted. We also know that additional doses of the vaccines will improve both the quantity and the quality of immune responses. So what about immunocompromised patients? We expect that the presence of immunocompromise will amplify the effects of virus variability. And we see this in the case, for example, of this data set from Israel, where just over 1,000 patients with immunocompromise were evaluated following 2 doses of the BNT vaccine. And their seroconversions for anti-S and also neutralizing antibodies were compared to those of 272 healthcare workers. And overall, the rate of seroconversion was reduced in immunocompromised patients. But what was interesting was the fact that the responses were quite heterogeneous, so that seroconversion rates were 99% for people with HIV and went down to 19% for heart transplant recipients. So quite heterogeneous responses. Of note, the population with HIV was largely on virologically suppressive antiretroviral therapy with good CD4 counts. We have also seen that clinically the risk of breakthrough infections following vaccination varies according to the different group of immunocompromised populations, being highest in this analysis in recipients of solid organ transplants. So this brief overview tells us that there is indeed heterogeneity among different groups of immunocompromised patients, and they all deserve their own research and their own specific recommendations about vaccination strategies. We also anticipate a degree of variability within each population of immunocompromised patients. This is well illustrated by the case of people living with HIV. We have learned that there is a subset at increased risk of severe COVID. We know that, of course, vaccination is paramount in this group, but we have also learned through the years that people living with HIV may have reduced responses to a range of different vaccines. These responses are modulated by CD4 counts, by the plasma viral load, and in clinical practice, we may use a number of different strategies, for example, giving more doses, selecting certain vaccine formulations rather than others to improve immunogenicity. This study told us very early on that immunogenicity is not affected by HIV in people receiving COVID vaccines. This study compared 54 people living with HIV, very uniform population, all virologically suppressed, all with a CD4 count greater than 350, to 50 controls, and found that there was no difference in the magnitude of humoral and cellular immune responses after 2 doses of the AstraZeneca vaccine, and kinetics over 182 days of follow-up were similar in the 2 groups. So very reassuring data. However, when we look at more heterogeneous populations living with HIV, we can see different results. This is a meta-analysis looking at 23 studies across the world and concluding that in people living with HIV compared to controls without HIV, there is a reduced likelihood of anti-S IgG seroconversion after receiving COVID vaccines. Of note, the difference was seen specifically in the study for people that receive adenovirus vectored vaccines or inactivated vaccines, but not for those that receive mRNA or in 2 studies, those that received protein vaccines. In terms of efficacy against symptomatic infection in people with HIV, there was also a modulating effect of a CD4 count above or below 350. This study, which is still undergoing review, also looked at the immunogenicity of a number of different COVID vaccines in people with HIV, all largely on virologically suppressive ART with a high CD4 count. And they compared responses to 440 controls and came to the conclusion that after adjustment for age, sex, and vaccine type, people with HIV had a reduced anti-spike IgG response. We can see from the graph that responses were especially lower for people receiving adenovirus vaccines overall, if we do a comparison with those receiving mRNA vaccines. And indeed, among people with HIV, factors associated with a reduced anti-S IgG response were receiving an adenovirus vector vaccine, age greater than 65, viremia, and a CD4 count below 250. The study from Rome looked at 250 people with HIV that received 2 doses of the BNT vaccine and had the anti-S IgG titer measured a median of 4 weeks after the second dose. In this population, 14% had a CD4 count of 350 or lower, and 10% had viremia. There was an impact of CD4 count on anti-S IgG titers, reduced in those with a CD4 count below 350, and more so in those with a CD4 count below 200. Other factors associated with the reduced response comprised also viremia. And this is an interesting finding because the impact of viremia was independent of the CD4 count. And in this population, viremia was really a low-level viremia. The median was 122 copies and the IQR went up to 439. Another study from Rome looked at follow-up a bit longer after 2 doses of an mRNA vaccine in people living with HIV at a median of 175 days, neutralizing antibodies and T-cell responses were lower in people with a CD4 count below 200. The same group had also reported an impact of CD4 counts on humoral and cellular responses after vaccination in the early follow-up after vaccine. So what can we conclude from this analysis is that COVID vaccines elicit good immunological responses overall in people living with HIV, but there is a subset with reduced responses. It is important to identify the risk factors for these reduced responses in order to target, of course, management strategies. Which factors can be considered? The current CD4 count is very important, as we have seen, presence of viremia independently of the CD4 count, age above 65, and perhaps some other parameters that are present are less well studied. It's clear that people living with HIV need additional vaccine doses, and this is a study looking at the impact of giving a 3rd dose, a booster dose, in people with and without immunodysfunction, and showing that the risk of breakthrough infections in the period between August 2021 and January 2022, so incorporating also the onset of the Omicron wave, the booster dose reduced the risk of breakthrough infection in people with immunodysfunction, although to a lesser extent than in people without immunodysfunction, but still important effects. But this study was especially important because it indicated also that the 3rd dose in people with immunodysfunction was associated with significantly reduced risk of severe outcomes. Now, important to appreciate that immunodysfunction here, the population with this immunodysfunction in this study comprise quite a variety of different populations, and it will be important to see how the data break down by group. Now, a third dose will be helpful to people living with HIV, will boost their responses, including their neutralizing antibody titers against Omicron, but there will still be a subset in whom responses will remain suboptimal, particularly in those that have not experienced a SARS-CoV-2 infection, as we can see from this data set. So what about a fourth dose? We have seen data emerging from Israel, admittedly these are still short-term data, that looked at the impact of giving a fourth vaccine dose to people aged 60 or above. We are looking here at people who had received 3 doses of the BNT vaccine previously, prior to receiving their fourth dose. And what the study concluded was that the fourth dose reduced the risk of infection, although this effect appeared to be short-lived during the quite short follow-up to week 8 of the study, but there was a longer and more durable effect on severe COVID, which is obviously encouraging. More long-term data will be needed. CDC has issued guidelines to incorporate this emerging evidence of the benefit of adding more vaccine doses, so that the primary vaccine course for people that have moderate or severe immunocompromise is based on 3 doses, and then 2 booster doses are indicated. So in summary, what can we say about COVID vaccines for people living with HIV? The available vaccines are safe and well tolerated. In people that are on treatment with good CD4 counts and suppressed viremia, the responses are comparable to people without HIV. We see reduced responses, immunoresponses in a subset that have identifiable risk factors, so we can use the risk factors to guide our management, prioritize for additional vaccine doses, consider other prevention tools. We believe that additional doses will boost immunoresponses, including immunoresponses against variants, and we expect these additional doses to increase protection against the variants. But we need obviously more clinical data and also data on durability. And finally, we need to make sure that we reach out, we identify those that remain unvaccinated or unboosted and ensure that they receive adequate protection. There are many research questions for people living with HIV when it comes to COVID vaccines. For instance, should we always prefer mRNA vaccines? What is the role of heterologous prime boost approaches? What will be the role of multivalent vaccines if they become widely available? Which biomarkers could guide our vaccination strategies in this population? For instance, could there be a role for an interferon release assay? And finally, how to best reach the vaccine hesitants. I'll leave you with these questions. Thank you.